Hello everybody, thank you for joining me today, and in today's video we're going to be looking at normocytic anemia as part of the high yield haematology edition. So just a little bit about the Medicine Guide. So the Medicine Guide is a YouTube channel which has free online videos to help support medical students throughout their entire journey at medical school. So I've got videos on how to approach anatomy, histology, PBL, CBL teaching. I've got videos focusing on the high yield imaging that crops up in final exams, as well as the high yield ECGs. I've also got the high yield topics that crop up in obs and gynae, paediatrics, cardiology and neurology. And this video, in conjunction with others, forms part of my high yield haematology edition. So if you enjoy my video today, please can you give me a thumbs up, please can you subscribe to my YouTube channel, and please share my video with your friends. So let's get started. So normocytic anemia classically presents on a full blood count with low haemoglobin and a normal MCV value. The causes of normocytic anemia is as follows: acute blood loss, anemia of chronic inflammatory disease, aplastic anemia, hypothyroidism, hemolytic disease such as G6-PDH deficiency, hereditary spherocytosis, and autoimmune hemolytic anemia. Now, the different diseases which are underlined in either red or blue will be described in a lot of detail in today's video. Anemia of chronic inflammatory disease is in a blue font because it can present as either microcytic anemia or normocytic anemia, but it's more commonly illustrated as normocytic anemia. So with that in mind, let's get started. So we're going to start off by discussing anemia of chronic inflammatory disease. So the risk factors of anemia of chronic inflammatory disease involves chronic inflammatory conditions such as rheumatoid arthritis, SLE, inflammatory bowel disease. So these are more chronic autoimmune conditions, as is polymyalgia rheumatica and scleroderma. Chronic kidney disease is an example of a chronic condition, and that can present with normocytic anemia, and ultimately that would suggest anemia of chronic inflammatory disease. Signs and symptoms of anemia of chronic inflammatory disease is as follows: fever, anorexia, night sweats, and some symptoms are more suggestive of the autoimmune disorder, like the rash, the tender joints and shoulder girdle. And then we've got some more systemic signs like hepatosplenomegaly and lymphadenopathy. In terms of tests, patients will present on a full blood count with either microcytic anemia or normocytic anemia, and normocytic anemia typically presents more frequently in these patients. The serum ferritin is high because serum ferritin is an acute phase reactant and it's raised during inflammation. Transferrin saturation is reduced and TIBC is reduced. I mentioned this in my previous video. You need to be very confident in interpreting the ferritin, the transferrin and TIBC values, because you might be asked to compare these values in a patient who's got iron deficiency anemia. So you need to be confident in how those values would present in anemia of chronic inflammatory disease and how they would present in iron deficiency anemia, because that's a very classical SBA that they can throw in. And the management of anemia of chronic inflammatory disease involves treating the underlying cause, considering a red blood cell transfusion, potentially considering erythropoiesis stimulating agents and supplementary iron. Now, the key thing to remember in aplastic anemia is that these patients will be suffering from pancytopenia and a hypoplastic bone marrow. So aplastic anemia can occur idiopathically. It might be congenital in some patients. It might be after the use of sulfonamides, phenytoin, NSAIDs, gold, and pregnancy can be considered a risk factor for developing aplastic anemia. Some of the signs that these patients will show is that they'll suffer from recurrent infections and epistaxis, which is nose bleeding. Other signs involve petechiae rash, blood blisters in the mouth, and ecchymosis, which is a description of a specific type of bruising found in these patients. And in terms of tests, so we need to perform a full blood count, and these patients classically present with a normocytic anemia. So because these patients suffer from pancytopenia, they will have a low platelet count, low neutrophil count and a low white cell count. And the bone marrow aspirate, like I said previously, will show hypercellularity. So if you just have a look at this bone marrow aspirate, hopefully you can appreciate that. And in terms of management, we can consider allogenic stem cell treatment if the patient's under the age of 50, but if the patient's above the age of 50, we would consider immunotherapy. So now we're going to look at G6-PDH deficiency. So this is more commonly found in men and in patients from an African or Mediterranean ancestry. And this is an X-linked recessive condition. So these red blood cells are more prone to oxidative stress, and this might occur after the use of sulfonamides, ciprofloxacin, aspirin, ibuprofen, broad beans, or even fava beans. So the signs of G6-PDH deficiency involves neonatal jaundice, dark-coloured urine, pigmented gallstones, and splenomegaly. Now in terms of tests and investigations, the full blood count will show normocytic anemia. Now because G6-PDH deficiency is an example of a hemolytic anemia, these patients will have a high reticulocyte count, high bilirubin, high LDH, low haptoglobin. And the peripheral blood smear in G6-PDH deficiency involves the presence of Heinz bodies, bite cells, and blister cells. Now, I would say be very aware of these key phrases because they do crop up time and time again in final exams. And also, we would need to perform a G6-PDH enzyme assay, and that's diagnostic of a G6-PDH deficiency. Management is to stop any precipitating causes, so if this is attributed to the use of a specific type of medication, then ultimately we need to stop that type of medication. And we would consider blood transfusions as well in these patients. So now we're going to look at hereditary spherocytosis. So hereditary spherocytosis is when the normal biconcave disc shape of the red blood cell is replaced by a spherically shaped red blood cell. There is now a reduced survival rate for this red blood cell because it's destroyed by the spleen. So essentially these patients are at greater risk of suffering from hemolysis as a result of this. So the risk factors of a hereditary spherocytosis includes the fact that it's more common in Northern European and Caucasian communities. It can occur in both men and women because it's an autosomal dominant condition. It's more commonly associated with patients who have a parvovirus B19 infection because it can lead to an aplastic crisis, and patients who suffer from an infectious mononucleosis are at risk of suffering from hereditary spherocytosis and are at risk of developing a hemolytic crisis. So in terms of signs and symptoms, patients can experience a failure to thrive, jaundice, pigmented gallstones, splenomegaly, and shortness of breath. In terms of tests, we would need to perform a full blood count to show the presence of normocytic anemia, and because hereditary spherocytosis is an example of a hemolytic anemia, there will be raised reticulocytes. And the peripheral blood smear will show the presence of spherocytes, such as this. We would need to perform an EMA binding test as a diagnostic test, and the osmotic fragility test is our investigation of choice, because these red blood cells show increased fragility because they're at greater risk of bursting. So in terms of managing these patients, we would perform folate replacement, and we would also consider splenectomy. Now this is the last condition of the day. We're going to cover autoimmune hemolytic anemia. So there are two types of autoimmune hemolytic anemias. We've got warm autoimmune hemolytic anemia, where we've got IgG leading to extravascular hemolysis at 37 degrees in the spleen. And conversely, there's cold autoimmune hemolytic anemia, where IgM is targeting the red blood cells and it leads to intravascular hemolysis at 4 degrees. So the risk factors of warm autoimmune hemolytic anemia involves SLE, lymphoma, the use of methyl dopa. It can occur in patients suffering from a chronic lymphocytic leukemia, and sometimes it can even be idiopathic. Warm autoimmune hemolytic anemia classically can affect both men and women, but usually it affects women who are of a middle age. whereas cold autoimmune hemolytic anemia is more commonly associated with lymphoma, mycoplasma infections, Epstein-Barr virus infections, SLE, cytomegalovirus infections, HIV patients, and patients suffering from a B-cell lymphoma or acrocyanosis. Some of the signs which are more specific to cold autoimmune hemolytic anemia involves Raynaud's phenomenon, and cold autoimmune hemolytic anemia typically affects patients who are of an older age. Now, the key symptoms found in either warm and cold autoimmune hemolytic anemias is the fact that the patient will experience splenomegaly and they will suffer from intermittent episodes of hemolysis where they will present with jaundice, anemia, and perhaps dark-coloured urine. So in terms of the tests, we would need to perform a full blood count which will show normocytic anemia, and because this is another example of hemolytic anemia, the reticulocyte counts will be high. The peripheral blood smear may show spherocytes, and a direct Coombs test is going to be positive in autoimmune hemolytic anemias. So the direct Coombs test is when a blood sample is taken from a patient with immune-mediated hemolytic anemia, and antibodies are shown attached to the antigens on the red blood cell surface. The patient's washed red blood cells are incubated with anti-human antibodies, which is the Coombs reagent, and a positive test result is when the red blood cells agglutinates, so you've got anti-human antibodies forming links between the red blood cells by binding to human antibodies on the red blood cells. So that's an example of a positive test result, and that's found in autoimmune hemolytic anemias. So in terms of managing these patients, we would offer prednisolone, and we would also consider a splenectomy. So this marks the end of my video today, so thank you very much for watching my video. I hope you found it useful. If you have, please can I kindly ask you to give me a thumbs up, subscribe to my YouTube channel, and share my video with your friends. I wish you all the best with your exams, and thank you very much for watching today.